Yeah, thanks so much, Jeffrey, and hi, Twee and Judy, for this invitation to talk about this. I love this topic. I've been working in this area ever since I accidentally went to a BMT conference when I was supposed to be doing NICU rounds or PICU rounds. So I've been working with my BMT colleagues for a long time on this and excited to tell you all about what we've been able to figure out. Before we get started, just want to list some financial disclosures. The only one relevant to this conversation is Jazz Pharmaceuticals. So they are the pharmaceutical company that makes the drug that is effective for VOD, but we won't be talking necessarily about the drug and a lot of the data behind that, because as radiologists, we don't prescribe the medication. We just help make the diagnosis and help with prognosis. So the objectives of my talk, I want to introduce you guys all to VOD, and you'll notice I put VOD SOS in the initial slide. So this is known as veno-occlusive disease or sinusoidal obstructive syndrome. For reasons, when I talk to the pathologists who deal with this, they say the occlusion, the sloughing is at the level of the sinusoids, but the occlusion is actually at the level of the hepatic venules, so they like VOD rather than SOS. And so since we use pathology for a gold standard, I'm going to use them again for the gold standard and mostly refer to this as VOD in my talk. I want to help you guys understand what ultrasound findings are in VOD and the timing of the findings, and then understand how shear wave elastography can be used in the future or even currently for early diagnosis. So hepatic veno-occlusive disease, the background is it's really best recognized as a complication of high-dose chemotherapy or radiation, especially after hematopoietic stem cell transplant. Really, it's not the transplant that causes the VOD, it's the chemotherapy and the radiation and the damage to the liver endothelial cells. Interestingly enough, this was actually first described in Caribbean natives. They would consume bush teas that contained high level of alkaline materials. They were metabolized in the liver, and again, they caused similar findings. They caused destruction of that hepatic endothelium. There's other things, again, this is what I learned from my bone marrow transplant colleagues, related to consumption of other materials that also do cause VOD. But of course, we see this mostly in the setting of stem cell transplants. So this is interesting to me, the VOD incidence over time and how often the transplanters are seeing this. So it's 5 to 15% after myeloablative stem cell transplant. So really, as I learned more from my transplant colleagues, there's two types of transplant. One is where it's a cancer or your bone marrow really has bad cells and you want to get rid of all of those bone marrow progenitor cells for your blood. And the other is reduced intensity, where you're just trying to get rid of some of those bone marrow constituents, and you're not concerned about getting rid of everything. So as you can imagine, if you're trying to get rid of all of those cells in your bone marrow, you usually use a lot more harsh radiation and harsh chemotherapy, and that's why this term is myeloablative. And so that's why this mostly occurs in that myeloablative setting. So in your reduced intensity conditioning, you see the incidence drops very, very low. Again, this myeloablative stem cell transplant has those myeloablative conditioning regimens that they give have lots of complications. And so they're using less and less toxic conditioning regimens, which is why VOD incidence is decreasing over time. So how does VOD develop? So as I mentioned, there's normal hepatic sinusoids. You get damage to those endothelial cells because you're giving toxic radiation or chemotherapy. All of a sudden they become leaky. The blood cells come through. These blood cells also clot off, and these endothelial cells drop out. And basically you get obstruction, actually at the level of the venules. So clinically, they've always diagnosed this with these two criteria. So these criteria have been used for many, many years. You can see the first papers were published in Seattle in 1993 and in Johns Hopkins in 87. Suffice to say, these criteria were all developed using retrospective data. and they really don't function well prospectively. So prospectively, these criteria, if you can imagine, it's very common to have hepatomegaly and weight gain after transplant. So these clinical criteria result in a lot of false positives, which is why the clinicians need better tools to diagnose VOD. Luckily, they've come up with some new VOD criteria. This is from the European Bone Marrow Transplant Consortium, and from what I understand, is fairly commonly used by our transplant docs, especially in the pediatric setting. And these are intended to be prospective. And one of the things I'll draw your attention to, if you're ever talking to our transplant colleagues, they will talk about refractory platelets or thrombocytopenia, and that's really one of the best signs for clinically for early diagnosis of VOD. But again, this is what we're kind of competing with for imaging. There are other criteria that were proposed by Mitch Cairo and his group, also intended to be prospective, and these are included here. And these two, just know that in the bone marrow transplant world, the two criteria are competing right now to see which ones will be more used in the future. So again, clinical criteria, there's legacy criteria, and there's more current criteria. The legacy ones are retrospectively defined, so they're not great. The current ones are prospectively defined, and they're already doing better than those legacy criteria. So again, Baltimore criteria, you'll notice that imaging actually could play a role here because hepatomegaly and ascites are part of that Baltimore criteria. In the modified Seattle criteria, again, hepatomegaly is a criteria there, so imaging can play a role even in those legacy criteria. In the new criteria, ascites and hemodynamic or ultrasound evidence of VOD is specifically called out. So I think the transplanters are realizing that imaging is more and more useful. So they're actually citing some imaging findings more explicitly in their criteria, which is, again, great for us and great for this collaboration. Pediatric criteria, even better. So Salim, who's a transplanter in Germany, who's just a fantastic person, he's really collaborated with the imaging people at his institution and here across the pond with some of us to, again, include imaging in his pediatric criteria. So it's fantastic that we're getting shout outs in the clinical criteria, but again, I think as we get more and more ultrasound evidence, especially the shear wave elastography, I'm hoping to see this us become even more prominent in their clinical criteria. And then Mitch Cairo, again, him and I have spoken many times, and he really believes in the work of imagers and believes that we should be more involved in the VOD diagnosis. So he's also cited some imaging variables in his criteria. So I just want to show you some images of patients with VOD and what you would see on grayscale imaging. So as you can see, VOD is primarily liver dysfunction. So if you think of any type of liver dysfunction, liver inflammation, you're going to see some of those findings reflected in VOD. So you'll see ascites and free fluid, you'll see gallbladder wall thickening, you'll see heterogeneity of the liver. You'll see hepatomegaly. Again, this is, for us, a measurement that we take. I think it's a tough measurement to take reliably from patient to patient and from time point to time point. But again, we try to take it in that same patient. And what we're looking at is kind of in the right midclavicular line. The pediatric definition of enlargement in the setting of VOD is greater than 1 centimeter relative to baseline. So again, this is why baseline exams are so important in the setting of VOD, because you'll see a lot of the VOD criteria are both defined in terms of relative to baseline and in terms of absolute value. And the relative to baseline definitions almost always perform better than those absolute values. So this was cited in the Lassaw paper in radiology. Again, you can see a lot of this VOD work before some of the current interest in it in imaging was done kind of in the 80s and 90s. So again, for hepatomegaly, This is one of their most important clinical criteria, and that greater than 1 centimeter is really useful as you guys think about incorporating this into your practice. And again, here's some of the normative criteria that hopefully we're all familiar with, and I've included those references there. So ascites is the other big criteria that's cited in those clinical criteria. What's interesting is, for me, ascites is always a gestalt, like what's mild, moderate, and severe. I think we would all agree with mild. If there's minimal fluid, I think we would all call it mild. Severe, if there's fluid that's fairly deep, I think we would all call it severe. I think moderate is where the definition is much more interesting. And again, when we practice clinically, we kind of have a big variance about what we all call moderate. But if you look, there is actually data out there. And so if you look at the evidence, Nishida and his colleagues in Japan have published ultrasound scoring system for VOD based on Grayscale and Doppler criteria, and this is how they defined mild, moderate, severe. And so when I'm reading a VOD study, I actually try to follow this mild, moderate, severe, because again, this is really the only evidence-based practice I can do for some of those Grayscale findings. So let's look at all of the papers that have been published in terms of Grayscale and Doppler criteria for VOD. And let's kind of compare and contrast and see what we can come up with. So if you look at Lassaw, this was the first one in 1997. Again, he retrospectively looked at patients who developed VOD, and he found these were common findings in those patients. This is the paper from Nishida and his group. And basically, he's also looked at all different, I think he started with maybe 28 findings and tried to narrow them down to the ones which he thought were most relevant in the setting of VOD SOS. So when we look at these criteria, what I like to do is at least compare the literature and see what is similar. So see what the takeaways are. Again, some of the best evidence we can get is kind of these meta-analyses where we put all of this together. We don't have enough studies quite for that yet, but we can look at least these two studies and compare. And what we see basically is the findings that we should think are important on Grayscale and Doppler: hepatomegaly, gallbladder wall thickening, portal vein diameter. So this is interesting. We usually don't measure this on our Dopplers, but we have been doing this more and more in VOD. Ascites, and then visualization of the periumbilical vein. So when I talk about to my adult colleagues, they constantly look for this in the setting of cirrhosis to look at some of those portal hypertension findings. And so this is something, again, that we weren't normally doing in peds, but that we do more of now that we do these VOD studies. And then hepatic vein diameter and splenomegaly were only part of Lassaw, so that's not something we really hang our hat on too much. So let's look at the Doppler criteria. So again, they have things like spectral density, flow demodulation, portal vein congestion index, monophasic flow. This is something that wasn't seen in Lassaw, even though they did look at, or in HOCUS, because HOCUS did base a lot of their initial search of that variable space on Lassaw. They didn't find that these were particularly useful. So let's see what both of them agree on. And basically what they agree on is the mean velocity in the portal vein is important. So if your portal vein is slow or it's reversed, you can think of VOD. The resistive index they both agreed on, and then that periumbilical vein signal. So looking at all of the other studies out there, there have been multiple other studies on VOD. They tended to look at only single variables or a subset of variables. And so I just wanted to summarize all of those for you on this slide. So you can see here are the studies, the primary studies listed here if you want to refer to them. But basically, there were some studies that were just negative. They didn't find anything associated with VOD on Doppler. There were some positive studies. A lot of them were main portal vein velocity. So this is really great because that's something that we had looked at before. Common hepatic artery RI, that's also something that we had cited before. And then they looked at portal vein peak systolic velocity. And I'm actually going to encourage you to look at that because I think that's actually a better finding than RI. So we also did our own study. We retrospectively looked at all of the data at Children's Mercy and saw who was diagnosed with VOD and who wasn't diagnosed with VOD, and had a Doppler ultrasound after their stem cell transplant. And basically, we found ascites was really useful. Main portal vein velocity was really useful, and then this peak systolic velocity was really useful. And so, let's see. Let me talk a little bit more about the peak systolic velocity and the RI and why I think the peak systolic velocity is actually a better finding. So if you looked at our retrospective data was nice because we just didn't look at a single time point at when these patients were diagnosed with VOD and when they got transplanted. We looked at all the ultrasounds that happened after transplant until patients were discharged. And basically what we noted in that common hepatic artery is early in the disease, when you were trying to diagnose VOD, the liver got more stiff. And so as the liver got more stiff, your peak systolic velocities went higher. So again, I think the hepatic artery was trying to compensate, trying to get more blood in because, again, the liver was more stiff, there was more resistance to flow, there wasn't as much flow in that portal vein. So the hepatic artery blood flow had to compensate. And so again, that peak systolic velocity went up because initially it was trying to get more blood in during systole. And so again, peak systolic velocity goes up because diastolic velocity stays the same, RI goes up too. And so that's what we're seeing. So RI and peak systolic velocity, they're both really good in early VOD. Well, in later VOD, you get even more hepatic congestion, you get even more portal hypertension, and the portal vein flow goes down even more. And now what happens is you've compensated as much as you can for flow in systole. Now you have to compensate for flow in diastole. So now your end diastolic velocity also increases. And so what this does for you is the peak systolic velocity stays high, the end diastolic velocity goes up, and your RI normalizes because it's a ratio between those two. And so when both of those things go up, the RI normalizes. And so that's why I think that peak systolic velocity is actually a better finding for veno-occlusive disease because it persists throughout the course of veno-occlusive disease, whereas the RI transiently goes up and then kind of falls back down. So again, Grayscale and Doppler findings, hepatomegaly, gallbladder wall thickening, they were positive in these two more comprehensive studies, negative in another study, portal vein diameter, ascites. And again, these are the findings that I think are really important in VOD. And again, this wasn't cited in the peak systolic velocity wasn't cited in either LASA or HOCUS, but I don't know if they specifically looked at them. But again, the studies that have looked at them have seemed to be positive. And there's a really good physiologic reason for it being positive. And you can again notice the RI was negative in some of the studies that were cited. And again, that might be because of that pseudonormalization at the end. So timing, this is really important because timing is crucial to VOD diagnosis. So in Nishida, they had 40% where the ultrasound score preceded the clinical diagnosis. And then our group showed that all of these things worsened as the VOD diagnosis became closer. So these are somewhat early findings of VOD. All right. I actually think that there's a slide that seems to be missing from this slide deck that I usually always present on. And basically that slide is talking about Defibrotide, the drug that's being given for VOD. And so the interesting thing to know about that drug is there's a huge mortality benefit from that drug. I think the mortality dropped from around 60% to around 30% if you gave the drug in a timely fashion. And the definition of that timely fashion was basically at the time of clinical diagnosis or 2 days after clinical diagnosis based on the Baltimore and Seattle criteria. What's really important there is that our clinical colleagues have a lot of trouble with these criteria because so many patients become positive for VOD or positive on these criteria, and only a few of them go on to develop VOD. because basically a lot of the things in the differential around transplant at that time are things that affect the liver. And so they have a lot of trouble saying, okay, these clinical criteria are positive. Is it VOD? Is it not? And so you ask, since the mortality is so high from VOD, and we really want to make sure that we're diagnosing this well and that we're treating quickly, why not just give the drug to everybody and then discontinue it when you know they don't have VOD? Or even better, just give everybody the drug prophylactically. And so some trials have been designed to answer these questions. The prophylaxis trial was sponsored by that pharmaceutical company, and that prophylaxis trial, even though they selected the most high-risk patients for VOD, that trial failed. So prophylaxis with that drug didn't change the rates of mortality in the end on their trial. So basically, prophylaxis is not a good strategy for that drug. The other thing to know is this drug is incredibly expensive. And so giving this drug to a bunch of patients who may not go on to develop VOD is not great for kind of the healthcare system in general and healthcare costs. So again, if there is a magic bullet where we can diagnose this early and more accurately, and they can just give the drug to those patients who will go on to develop VOD, we will be of immense help to our BMT colleagues. And so again, you can see in 40% of the cases, we can do that with this ultrasound score, but we're still missing about over half of our patients. So what can we do about that? Let's look at elastography. So does elastography have added value in VOD SOS? And the reason that we came up with this question, again, was this is a portal hypertension state. So we thought if this is a portal hypertension state and there's more vascular congestion in the liver, just like in the Fontan patients, you should see the stiffness go up. So again, our inspiration was the liver congestion. So this was a paper by Dr. Dillman, which basically showed once you completed the Fontan and caused that passive hepatic congestion, you saw a huge change in IVC pressure. And you saw a huge change in elastography values. So hypothesis, we thought that they would have stiffer livers. We did a single center study. We included patients who received myeloablative conditioning regimens. We did it at 3 time points. Again, we did it before bone marrow transplant. So this is that baseline. And then we did it at 2 times after transplant. And we also performed the ultrasound elastography with any clinical scans where they were suspicious. So we were able to enroll 26 patients. 5 of those went on to develop VOD. So you can see over the course of, I think, 2 years, you don't see that many patients who have high suspicion of this. So that's another tricky thing about this diagnosis is it's a pretty rare disease. And again, one of those patients was severe enough to require that drug, and another was had a severe enough ascites, which was causing respiratory compromise that they had to put in a drain to drain that ascites. So if you look, here are our patients. The one on the left did VOD eventually, the one on the right didn't. And you can see the one on the left has higher liver stiffness based on that color scale and based on the numbers. And the one on the right, the liver stiffness stayed fairly similar throughout their course. Again, we can see this when we compare those 2 groups. So the VOD SOS group, you can see the liver stiffness went up throughout the examinations, and then the non-VOD SOS group, it actually went down. You can look at all of these other variables, which we thought would be really useful because we had shown them to be useful before, but because of small sample sizes, we didn't find that any of these were significant. The main portal velocity, vein velocity got close, but it didn't quite get there. So again, looking at Doppler variables, looking at elastography seems to have a much bigger signal relative to the Doppler signal. So again, this is really good evidence that elastography might be a future way of diagnosing VOD more effectively. So again, we look at our 2 patients, and here's basically the graphical representation of some of that data before. And you can see if you didn't go on to develop VOD or SOS, basically your liver stiffness stayed the same throughout the course, but if you did, it increased throughout the course after transplant. These are the individual patient tracings from that. So again, I showed you aggregate data before. Now I'm showing you individual patient tracings. And you can see on these individual patient tracings, pre-transplant, they're kind of all in this area. And you can see even by day 5, a lot of them are starting to increase above baseline, except for this orange one, who actually was one of the more interesting ones because they were diagnosed clinically at the same time they were diagnosed with elastography. So the star basically is when they were diagnosed clinically with VOD, and the plus is basically when they had reversal of flow or were diagnosed by imaging. So you can see even at day 5, when things were starting to move up, there wasn't a clinical diagnosis yet. At day plus 14, most of the stiffnesses went up quite a bit, and so they were able to be diagnosed. You can see these day 14 dots before both the clinical diagnosis and the Doppler diagnosis. So when we look at the area under curve, at day plus 5, you can see the area under curve is 0.78. So not great performance, but definitely better than our Doppler criteria. And this is a super early signal. Remember, you only need to diagnose it about 2 days before, or even on that same day of clinical diagnosis. And again, day plus 5 would be super early. So for those patients who had signal at day plus 5, this is fantastic because they could give that drug early and definitely improve patient outcomes. But even at day plus 14, a lot of these patients had not developed VOD yet, and the area on the curve you can see is much better. And so if we can do it at day plus 14, that's great for our clinical colleagues and give them more certainty that this will go on to develop VOD, go ahead and give that drug. So again, that's just one study. That's my study. I'm super biased. Why take my word for it? And I don't want you to. I want you to critically examine some of the other elastography literature that's out there too. And so there are 3 studies that were done in Europe. So these are, again, small prospective studies. If you look at this, it's only 22 patients, 4 went on to VOD. This is 78 adult patients. And you can see the adult incidence is much lower. And you'll see that's why pediatric transplanters, pediatric radiologists are a little bit more enthusiastic about this disease or more informed about this disease because it happens more. Relative incidence is higher in peds. And then there was a peds transplant study where they followed 3 patients. And so let's look at some of the evidence from here and see what it shows. And so basically this is their same thing. They did time points at baseline around 5 to 7 days and again around 10 to 14 days. And you can again see these patients with VOD, all of their stiffness is increasing definitely by the 10 to 14 day time point. And they even had some in that 5 to 7 day time point. So it's great. These 2 studies seem to match up. It gives a little more confidence when you're trying to generalize this data to your practice. So again, the liver stiffness increased 3 to 6 days before clinical diagnosis by the Seattle criteria, which again is great because we're trying to diagnose this earlier. And what's interesting is there were patients who had liver toxicity. So these patients who get stem cell transplant and get this conditioning regimen are at risk for drug-induced liver toxicity. They're at risk for acute GVHD. There's just increased congestion in the liver from some of the inflammation in that transplant. And there's, trying to remember the other one. It's another microvascular complication of transplant. The name's escaping me, but they all happen around the time of potential VOD diagnosis. And you can see in those patients who were diagnosed with those other forms of liver toxicity, the liver stiffness did increase, but it was a slower rate. So there is a way on elastography to differentiate those things that are front and center in their differential diagnosis with VOD. So again, here's the adult data. Again, you can see that all of these liver stiffnesses are increasing well before they're actually diagnosed with VOD. And then you can see this is the liver complication other than VOD SOS, and you can see that increases, but much more slowly. So even though these two got to the same time points, you can see that the VOD was trending up far before the yellow line in that other patient. And so if you're not familiar, there are grading scales for or organ toxicity. And this grading scale is 0 to 3, which is kind of mild to moderate, and then 4 to 5, which is moderate to severe complications. And so when you look at the liver complications after transplant, they broke it into 3 categories: patients who didn't have much liver toxicity after transplant, patients who had severe liver toxicity after transplant of some kind, but it wasn't VOD. And then these are patients who went on to develop VOD. And again, you can see in their liver stiffness measurements or their elastography measurements, even if you had severe complications of your liver after transplant, your stiffness didn't bump quite as much as it did in VOD. So if we go back to John Dillman's study, we look at the Fontan patients. The Fontan patients jump a lot. Liver fibrosis patients kind of jump a little. And so this is what we're kind of similarly seeing in VOD SOS. And this actually has implications for how you perform the exam. So if you're thinking about shear wave elastography in the liver, we tend to want our patients to be fasting so that we kind of take off the variation that's due to the postprandial state. We want our patients to basically breath hold, kind of mid-inspiration. So again, we're taking off some of that diaphragm compression in that VOD SOS, and we always want to measure in the right liver. So again, we're taking out some of those cardiac variations in those liver stiffness measurements. And that's really important when you're trying to grade fibrosis, because again, your fibrosis changes are small, right? From normal to fibrotic, the changes are small. So if you introduce some of that variation from postprandial states, from the heart, from the diaphragm, from breathing, you might pop somebody from this category to this category, or from this category to that category. But because VOD is such a huge difference between those patients who go on to develop VOD and those who don't, a lot of these things are less important. So as we've run our study, we've really relaxed our NPO times for elastography. We've relaxed those breath holds. And that's actually good because, again, if you've gone up to your transplant unit, you'll know what I'm talking about. These patients are neutropenic. They're usually don't have great appetites. They're pretty uncomfortable after their transplant. So the more we can make this exam easier for them, the more portable we can make it, the more accessible we can make it, the better compliance we have. And basically, my sonographers are a lot happier too, because they don't have to enforce these things on these patients who are already uncomfortable. And the other thing to know is that VOD incidence tends to be highest in our youngest age group. And so patients in my study, some of them have been 6 months old getting transplants for osteopetrosis. That patient's not going to breath hold. So again, when we can relax some of these settings for elastography in this particular clinical setting, I think it's really helpful in getting the studies done and helping our patients. So again, if you look at these adult patients, the increased stiffness was also earlier than clinical criteria, and this was even better because it was earlier than the EBMT criteria, which in turn are earlier than those Baltimore and Seattle criteria. So again, elastography looks like it might be the way forward if we want to give our colleagues some early clinical diagnoses of this. So let's look at those 3 patients from pediatric transplantation. And what we notice here is they've set a cutoff of 8 kilopascals for when they think VOD should be diagnosed. And again, here, if we look at it, the VOD diagnosis, their liver stiffness was starting to, again, increase before they got diagnosed with VOD. And then what's really interesting here is, when do you stop this drug? So this is an interesting drug because when they went for their FDA approval, they said, give 21 days of the drug, no matter what. And so they got approved for a 21-day course. Again, I mentioned this drug is really expensive, so each additional day is quite expensive. So what a lot of centers have been doing is they've been trying to figure out, can we stop this drug early? Because again, why not stop the drug early if the patient's kind of over their VOD risk? And so what they've been doing is they've been trending bilirubin as a marker of hepatic dysfunction. And basically, as the bilirubin starts to drop, they've been stopping the drug. Well, Zama showed something really interesting is, well, VOD, the liver stiffness drops as you're treating these patients with defibrotide. So let's look at this second patient. I think this is even more illustrative. So they started defibrotide here and they were trying to figure out when to stop it. And they kind of slowed it down and stopped it all the way here. So looks like here they gave even more than a 21-day course. But you'll see that the liver stiffness actually drops before the bilirubin drops. So this is definitely an area of future research is, can we actually use shear wave elastography to kind of figure out when to stop this drug? And again, here you'll see on their third patient, again, your liver stiffness is dropping well before your bilirubin is dropping. So again, area of future research, super interested in it. I don't think that the drug company is particularly interested in this line of research, but so far they've been great to work with. So they might actually be interested in this too. So what was really promising and what just came out about 2 years ago was this study that was done in Italy. So this was actually a large prospective adult and pediatric multicenter trial. So again, I presented some small multicenter trials showing that elastography was useful. But again, the question with these small trials is it generalizable to a bigger audience? And then are you just seeing results because you had such a small patient population? And will this hold up over a larger population? This was done with ultrasound elastography. They did use shear wave elastography, which we use a lot, and they also use the FibroScan, which is transient elastography for VOD diagnosis. So this is even more generalizable because they were using multiple types of elastography. They had the baseline and then 3 different time points. You'll see these time points look very familiar. And the clinical criteria were varied. They ran this trial for 6 years. So this is why it took so long to report out, but they had over 1,000 participants at 25 locations. So this is, in terms of prospective clinical trials, this is a huge prospective clinical trial. They included adult and pediatrics, all stem cell transplants. Here were some exclusions. These were exclusions mostly because they were using FibroScan. I think some of these exclusions may not be as relevant if we were using shear wave elastography all the time. But again, because they were using FibroScan, these were exclusions in their trial. The VOD incidence, as you'll note, and as I keep trying to mention, is that the adult incidence was lower, the pediatric incidence was much higher. The adults and pediatric patients did require treatment. So here are the results from their study. This is from their poster presented at the European Bone Marrow Transplant meeting. And then I have some other figures from their preprint article, which is in Lancet. And so you can see the patients that didn't develop VOD. It's almost the same as that graph I showed you from our single center study. Basically, their liver stiffness stayed the same throughout the course. But those who went on to develop VOD, again, it increased throughout their course. So this is great. All of the clinical data seems to be matching up. What's interesting here is if they didn't develop VOD, as you would expect, the liver stiffness measurement at diagnosis or at baseline was low, mild, moderate, severe, very severe. It seemed that there was a trend towards that going higher and higher. But again, we'll need more evidence here. So this is their algorithm. So if you look, they ended up including 800 patients, 46 of them got VOD, and this is their algorithm for us. So they say you should rule out VOD if the liver stiffness doesn't go above 6 kilopascals. If your liver stiffness is above 25 kilopascals, it's VOD. There's no other post-transplant liver pathology that raises your liver stiffness that high. If you're in the gray zone, that's when you really need that baseline. So again, 502 you were able to rule out, 27 you were able to rule in, but about 300 patients, about 40% of your patients fall in this gray zone. And this is why that baseline is so important, because you want to see if the baseline goes over 2 times the liver stiffness value. And this is what you'll get if you follow their algorithm. So basically, if you look, you'll get a positive predictive value of 94, a negative predictive value of 97. You'll notice that the specificity is amazing, 99%. The sensitivity isn't quite as good, so 80%. So you will have some false negatives in there. So again, not the magic, not like completely accurate, but what diagnostic test really is. And this one performs pretty well. So it's nice to see that the algorithm performs well on a big cohort. I do want to tell you about a North American study. We're actually running this study at Children's Mercy, and you can see the other hospitals where it's being run. We actually just completed our enrollment. So 250 patients have just been enrolled. Some of them are still going through their post-transplant course. So I have some fantastic collaborators at St. Jude in their statistics and bone marrow transplant department who are starting to look at that data now, and we're hoping to have that data published next year. The real difference between this North American study and the Italian study is, number one, we did a lot more time points. So they only did 3 time points after transplant. We did about 8 or 9 points after transplant. And I think there's going to be some really interesting results from that when I initially looked at that data, but we'll see how the final data analysis comes out. The other thing is we only used shear wave elastography, so we didn't have some of those exclusion criteria. And then our data is much more pediatric patients compared to adult patients. And so this is more relevant for the SPR community. I also wanted to tell you about an SRU consensus criteria that we are in the process of. So we have some fantastic transplanters who have been part of this. We have some fantastic adult radiologists. And Judy and I are the pediatric representatives, and then we have an IR representative as well. And so we'll, out of this consensus criteria, I'm writing up the manuscript now, but we'll have a lot of suggestions on basically how to perform an exam for VOD, what grayscale parameters to put in, what spectral Doppler parameters to put in, and then how you should incorporate elastography. And then more importantly, we'll put in a suggestion for baseline. We're hoping to co-publish this in a radiology journal and a transplant journal. So hopefully you guys will see more orders for baseline studies soon after this comes out. So basically, take-home points, I want to let you know that the clinical criteria now incorporate imaging. So I know the bone marrow transplant team wasn't super familiar to me because they generally come down for infections after transplant when patients are in that neutropenic stage. But again, they usually come down with ID, so I didn't know the team very well. But I think we really do have a role in their clinical work. And hopefully that this can encourage you to collaborate more with the transplanters at your institution. And again, their clinical criteria now incorporate imaging, so that's a really good way to start that conversation. Baselines are really useful. We really need them to order this because they know when patients are coming in for transplant, and they can order the baseline well before they start that conditioning. And remember, this is a baseline before they get the chemo and radiation, not a baseline before they get the transplant, because again, this disease starts once they start getting that radiation and chemo. So remember, if you're talking to them about baselines, the baseline is really before the conditioning. A good thing to know is they often do order studies before they start the conditioning, because they'll usually order central lines, they'll usually order things for infections. So that's a good time to get the ultrasound baseline too for patients who they consider at high risk for VOD. Grayscale and spectral Doppler has a key diagnostic role, but again, it's often too late to change treatment and figure out when to give that drug. So this is really useful. I think this will always be the big workhorse for VOD in the near future. But just remember, a lot of these findings are late. So again, another point of discussion with your transplant colleagues when they come down to talk to you about VOD. And then ultrasound elastography, it's been validated in a large trial in Europe, numerous small trials here. And so please talk to your transplanters about that if they're not already knowing it. That's kind of all I have. So I'd love for this to be more interactive and to have a discussion. So just let me know if you guys have questions.
Thanks so much, Sherman. That was really awesome. Really nice to see just a very comprehensive overview of all the literature and everything all in one place. So thank you for that. Yeah, if anybody has any questions, feel free to submit them, and we will happy to discuss those. I'm curious just to kind of kick things off. I know you kind of alluded to it at the end, with the consensus criteria that you and Judy are working on, but I'm curious to discuss from your kind of day-to-day clinical practice, kind of what your approach is to these patients. So one thing I know we're not doing here that I'd love to talk to my transplant colleagues about would be, that baseline examination. So it sounds like you're kind of doing that as standard for all the transplant patients, that they're getting a baseline. For that baseline, is it all three? Is it a Grayscale, Doppler, and elastography, or what is your kind of approach? I know that's kind of the big discussion here, is when they have clinical concern for these, which of those three things do we need? So I'm curious just kind of your general kind of day-to-day approach to these patients in that regard.
Yeah, so from our day-to-day practice, we rely on our transplanters to figure out who's high risk. So again, we probably transplant 60 people at our center, and they only think maybe 20 of them are high risk. And so in those high risk patients, they have been getting all three. They've been getting the Grayscale, again, mostly to look at that liver length. I think that's the thing that helps most. And then they have been getting the elastography because, again, we found that those relative values are really useful because some of the time these patients are coming in with hepatic metastases, or they're coming in for blood cell disorders where they have transfusion-associated liver disease. And so they have elevated stiffness in those livers before. And it's good to know that because, again, if you saw elevated stiffness later on, you might say, hey, this might be early VOD. But if I have that baseline, you can say it's definitely not. And then some of those elevated stiffnesses that we were seeing, so we've been using a third increase or 35% increase from baseline. Some of the interestingly, if you look at our data, the patients, I think this might be just small sample size, and I'm really curious to see what happens when we get the data from our larger study. But if you looked at that preconditioning ultrasound, at least these 5 patients in their preconditioning ultrasound, it was actually lower liver stiffness than that non-VOD group. So when you looked at some of these day plus 5 ultrasounds, they fell within the normal range. And so you would have called that study normal, but knowing that their liver stiffness was actually lower before coming in allowed us to say, hey, we should be suspicious for VOD, even though absolutely by an absolute scale, these are normal. Does that help?
Yeah, no, that totally makes sense. So I'm curious. So for these high risk patients, if you get a baseline ultrasound and then they start undergoing treatment, do you kind of have a routine kind of cadence of getting routine ultrasounds at certain time points, or is it more based on clinical factors and how they're progressing and what the clinical suspicion is, whether they get a follow-up or not?
Yeah, so that's a great question. So again, that's part of what we're trying to figure out with the consensus criteria is should there be a natural cadence? And this is one of the things that's kind of the trickiest thing to do. But we have really good, at least at our place, we have really good communication with our transplant colleagues. And so they have a super low threshold for getting studies. So we haven't been putting patients necessarily on a regular cadence. I think the patients with osteopetrosis who have an amazingly high incidence of VOD, I think it's upwards of 50%. They've been putting them on a regular cadence because they're just very, very high risk. But for those regular high risk patients, we've just been saying, hey, just have a super low threshold we trust you guys. We don't necessarily need a regular cadence.
Okay, that makes sense. Then the other question I was curious about, as far as, do you have a kind of unique reporting template that you utilize for reporting out these examinations? Like I'm thinking about our elastography template is mainly geared towards, Fontan patients, and we kind of have a disclaimer at the end about all the kind of confounding factors, but it's very much, they use the KPA for kind of monitoring the trend in any individual patient, but we kind of have some of those caveats about, whether hepatic congestion, some of the other things that can affect that number. But I think that the way that at least that our current elastography template is written, I don't think would necessarily clinically make sense for this patient population. But I'm curious if you have a kind of standard reporting template that you use for these. I'm also kind of thinking just from the context of, my group of 20 radiologists, just kind of making sure that we're describing these patients relatively similarly and not all over the place with what we're saying about these patients. I'm curious about that.
Yeah, thanks for the question. So we do have a standard template we use. It's been published. It's part of a multidisciplinary consensus criteria that Chris Mahadejo published. He used to be at MD Anderson. He's now at Duke. But if you look up that paper, and again, I could send you the paper and the link.
Okay. Yeah, that'd be awesome. And then one other question I have about the hepatomegaly, I think you'd mentioned a centimeter difference from baseline is kind of your threshold for calling it an increase in liver size. We, like you had kind of talked about, we definitely struggle with the consistency of that measurement. I think even if we had the same patient measured by 5 different sonographers, there'd probably be more than a centimeter variation. I'm curious how reliable you've found that particular criterion to be.
Yeah, so I think our sonographers have gotten fairly good at looking at the prior sonographer's actual image. And so again, most of the time they don't have to, most of the time they place it down and measure it however. But now that we worry more about this 1 centimeter, our sonographers have gotten better, at least
Okay.
in the patient population.
Okay. Yeah, that makes sense. I think if we really emphasize the kind of importance and why they need to be as consistent as possible, then maybe that would take away some of that variability. Yeah, but we definitely see that kind of just with our routine exams right now.
Yeah, agreed.
And then I think I wrote down a couple things here. One other question, kind of back to something I already asked before, was for the follow-up examination. So if you have a patient gets a baseline, or if they didn't have a baseline, they just come in with clinical concern. It sounds like you'd always suggest doing elastography for most of the time in these. Is there ever a time you think that either just Grayscale alone or Grayscale and Doppler is sufficient, or do you think elastography is always worthwhile if there's some suspicion of VOD?
Yeah, so that's a great question. So initially we had just been doing elastography, and then if they were diagnosed with VOD, we kind of stopped the elastography. So we're like, what's the point afterwards? And we would just kind of trend them with Grayscale and Doppler to look for that reversal of flow getting better. But I think that transplanters are starting to come around to the idea of using elastography as a way to taper off that drug.
Okay.
That
So
would
in
be,
general, the vast majority of the time you think elastography is warranted for these patients. I think that'll be a change for us, and I think it's just extra time for our sonographers. I think we always talk about in this conference, the balance between the time we spend imaging and the clinical benefit, and especially with Doppler and elastography and the kind of extra add-ons. But it seems like you have pretty compelling argument for elastography really having a lot of value in these patients.
yeah, I'm hoping some of the elastography data comes out even stronger in some of these trials, and then maybe we can just trend with, again, I worry about these exams taking a long time too. So I wonder if we can get rid of some of that Grayscale Doppler and
Right.
follow primarily with elastography. Because again,
Right.
that's a much quicker exam than a complete abdominal Doppler.
Right. Yeah, exactly. That makes sense. Right. I think that was all the questions I had. I don't know if Judy had to, if you had anything else to add. I don't have anything in the chat at this point in time, but
No, I guess for the liver measurements, like I guess there are maybe a few out there, but the ones that I've looked up, I feel like my patients are always, or they tend to have hepatomegaly. So I always I don't know, like, do you have like, I know you flash like some values, and I don't know if you found that particular reference better than most. Because after a while, like I was like, the liver doesn't look big. The left lobe isn't ginormous, the caudate lobe isn't big either, but the measurements like always fall higher than normal range. But then in those cases, I just opt out to not say hepatomegaly. But yeah, how do you guys kind of deal with that in
Yeah,
normal patients and here?
yeah. So in normal patients, I'm kind of like you. I rely more on kind of the morphology of the liver and what I can visualize in my head as a 3D volume of that liver to say if it's hepatomegaly or not. Again, if we get baselines, all of this goes away. We don't have to use those absolute measurements. But again, I think if it does, I don't necessarily use those measurements, honestly. I tweet like the absolute ones just because we get baselines. And if we didn't get baselines, I, like you, would probably still read it the way that I normally read it, which is trying to figure out in aggregate, does that look big? And again, you have to remember the thing that we are competing against is the clinicians feeling that inferior border of that liver. So I think we can do better than that by ultrasound.
Have you added in a category like a painful hepatomegaly thing for your text? You know how we do sonograph and Murphy sign for everybody? Maybe like a transducer compression tenderness scale or something? Or I guess just plus or minus pain.
Yeah, that's a good question. We haven't done that. But yeah, that's the classic clinical criteria is painful hepatomegaly.
Let's take that from, or let's cheat, right? Like
Yeah.
the text know if the kid has pain when they're smashing. Let's use that information too.
Mhm.
But I'm gonna add that to our protocol. Thank you.
Of course.
Yeah, yeah, it's kind of interesting on the liver lengths. Like we routinely measure the length on the ultrasound and we compare to these charts. And like you're saying, actually, a lot of them are out of the range. But I think like when we read CT or MRI, I almost never say the liver's enlarged on there. Just I'm not routinely measuring it, but it visually doesn't look big. So I think there is a real lack of kind of reliable data. And that one chart you showed also has a comparison to patient height, which I think I find helpful sometimes. 'Cause sometimes you have really tall kids and their liver's just big just because they're large patients. So I kind of look at the height. If they're 99th percentile for height, I'll give them more leeway even if the liver measure's big. But
And this is something we struggled with the SRU consensus.
yeah,
What are we going to do with this mid-clavicular line liver measurement? Because we all know it's unreliable.
right, yeah, for sure.
There were even spleen discussions about spleen length versus 3D volumetric estimation of the spleen. And again, you're at a trade-off, right, of sonographer and radiologist time versus being more accurate.
Right, yeah, exactly.